look at the histological pictures of some of the body tubes, we can start with the description of the gut tube, but we have to understand, may it be the gut tube or respiratory tube or the renal tube, the genital tube, their basic architecture is almost similar. So we'll be looking at the various details of the gut tube, the respiratory tube, renal tube, or genitourinary tube, but we are starting with the gut tube. Let us draw a diagram of the gut tube to describe various layers we find in the tube. And as we draw the gut tube, we are showing this is the lumen where the food matter will be passing through, and it is lined by the mucosa. Then under the mucosa, we will be having another layer, that is the submucosa. We can show it here. And exterior to the submucosa, we have got the muscular externa, which we are showing here. And exterior to the muscular externa, we have got the serosa. Now we will call it as serosa if we were having a covering of the peritoneum. But sometimes we do not have the peritoneal covering. For example, the esophagus is a gut tube, but most of it is not lined by the peritoneum. In that case, we'll have some connective tissue and we will call it as connective tissue adventitia. So these are the four basic layers of the gut tube, and when we focus upon the innermost mucosa lining the lumen, it itself is having three layers. Just very close to the lumen, there will be a mucosal epithelium, and you can mention here. Under this mucosal epithelium will have some subepithelial connective tissue, which is called as the lamina propria. And then deep to that, we have a smooth muscle layer, which is called as the muscle of mucosa or muscularis mucosa. Now, as we understand, the epithelium gives us the glands, and these glands mostly are found in the mucosa, but they can migrate towards the submucosa as well. Like in esophagus, we have submucosal glands, but usually they are in the mucosa. So it is the epithelium which can form the glands. Then we can discuss some of the ganglia and the plexuses which are found in the various layers of the gut tube. For example, in the submucosa, we are having what is called as the Meissner's plexus, whereas if we are talking about the myenteric plexus, it is in the muscular externa, and we are also calling it as the Auerbach's plexus. Now here, the ganglia which we find are in fact the parasympathetic ganglia, though we understand that even the sympathetic nerve fibers are coming here, but the ganglia will be parasympathetic. And what is the function of these parasympathetic ganglia? Parasympathetic system is for evacuation, and to do the evacuation, it has to increase the peristalsis and relax the sphincter, so that whatever food matter we are having in one component of the gut tube will be pushed into the next component of the gut tube. Evacuation of food matter to the next segment. And now we can discuss one disease, the Hirschsprung disease. In Hirschsprung disease, what happens is there is a problem of neural crest cell migration. Neural crest cells are not migrating to the distal part of the colon. And as we know, the neural crest cells are supposed to form the ganglia. If we do not have the neural crest cells, then we will not have the ganglia. So we are missing the Meissner ganglia and the Auerbach's ganglia. That is why there will be problem of evacuation. Peristalsis is affected and the sphincters are not getting relaxed, leading to retention, fecal retention. And when there is fecal retention, the colon becomes large, megacolon. This problem is since birth, so congenital, and there are no ganglia, so aganglionic, and colon is large due to fecal retention. Congenital, aganglionic, megacolon. That is the other name for Hirschsprung disease, and we will be discussing about this congenital aganglionic megacolon again. But the basic problem is neural crest cells not migrating to the distal colon, hence there are no ganglia in the distal colon, resulting in problem of evacuation and fecal retention. Now let us look at a similar diagram which we are having and revise the facts quickly once again. And as we mentioned, the gut tube is having the lumen where the food matter is passing, and this lumen is lined by the mucosa. Mucosa itself is having the three layers which can be seen here. Lining the lumen is the mucosal epithelium. Under that is subepithelial connective tissue, lamina propria, and still exterior to that is the muscle of mucosa, muscularis mucosa. So these are the three components which we are having in the mucosa. And we mentioned that the epithelium is forming the glands. These glands can be in the mucosal epithelium, extending into the lamina propria, but they can also move into the submucosa. So let us move on to the next layer, which is the submucosa. And exterior to the submucosa is the muscularis externa. The outermost is serosa if you have peritoneum. If you do not have peritoneum, peritoneum, then we will call it as connective tissue adventitia. As we mentioned, in the esophagus, most of the tube is lined by connective tissue adventitia. Now, we have got the sympathetic and parasympathetic fibers reaching here. We have to remember the sympathetic system is for storage. You can remember S for S, whereas the parasympathetic system is for evacuation. And we have known how is it doing evacuation by increasing peristalsis and relaxing the sphincters. It is antagonizing the sympathetic system. Now, if we talk about the ganglia will be only the parasympathetic ganglia, and we have named them. Let us zoom this area we were mentioning. If it is in the submucosa, then we'll be calling it as the Meissner's plexus, and if it is in the muscle layer, then we will call it as Meyenteric plexus or the Auerbach's plexus. This Auerbach's plexus or the Auerbach's ganglia, they are the one which are missing in Hirschsprung disease. Though in Hirschsprung disease, not only the Auerbach's ganglia are missing, but the Meissner ganglia are also missing. But if you have to choose between the two, the first answer should always be Auerbach's ganglia, because most of the authors mention about that. Now, submucosal plexus is in the submucosa, but the Meyenteric plexus, as you see, it is sandwiched between the two components of the muscular externa. In the muscular externa, usually will have an outer longitudinal muscle layer and inner circular muscle layer. And between this inner circular, outer longitudinal muscle, we have this Auerbach's plexus. And now we can move on to the details of other body tubes as well. We'll be looking at a diagram where we are focusing upon various parts of the gut tube like the esophagus, the stomach, the intestine, and we can compare it with the respiratory tube as well as the renal tube. So let us move on to the diagram. This is the diagram where we are looking at the various components of the gut tube, starting with the esophagus. We can move on to the stomach details, and then we have the details of small intestine. This gut tube, will be comparing it with the respiratory tube, for example, the trachea. And then we are also looking at the renal tube, say for example, the urinary bladder. We also look at the epithelium, which is covering the skin. Actually, the epithelium of the skin is matching with the epithelium of the esophagus. But there'll be some differences. And what are the differences? We'll definitely find out. At the moment, let us magnify this diagram, which is showing the various layers of the gut tube, starting with the esophagus here. Here we can find the three layers of the mucosa. Number 1, the epithelium. Number 2, the lamina propria, and number 3, the muscularis mucosa. So in the mucosa, we are having the epithelium, under that subepithelial connective tissue, the lamina propria, and then a thin layer of muscle, the muscle of mucosa, muscularis mucosa. Now, after the 3 layers of the mucosa, we have got the submucosa, then we have the muscular externa, where we have the inner circular layer and outer longitudinal muscle layer, and exterior most is the connective tissue adventitia. As we mentioned, most of the lining of the esophagus is connective tissue adventitia. Only the distal component, when it is meeting with the stomach, there will have the peritoneal serosa. And when we are looking at the epithelium of the esophagus, it is stratified squamous epithelium. It is similar to the epithelium of the skin, but there is one basic difference. Skin is dry surface, so it will be keratinized, whereas the esophagus is a wet surface and it will be non-keratinized, stratified squamous epithelium. Now, the glands which are formed are usually in the mucosa, like in lamina propria. But in esophagus, there is one peculiar finding that the glands are present in the submucosa, which is a rare finding. You can find glands in the submucosa even in the proximal duodenum. Otherwise, the glands are usually found in the mucosal layers. And then one question comes, it is asking which is the strongest layer of the esophagus. It is a controversial question, but it is the submucosa which is the strongest layer of the esophagus, and it is the same for the small intestine as well. The clinical relevance of this fact is, say for example, we are having a case of gastric cancer and we have done surgical dissection of the stomach. In that case, we have to anastomose the esophagus with the small intestine. And when you are doing so, in your suture, you have to include the submucosa, the strongest layer of esophagus, and also the submucosa of the small intestine, so that the sutures are strong. Now we go back to the same diagram which we were having for the comparison purpose. And here we would like to compare the esophagus with the stomach. As we magnify this diagram of the stomach, we will find some of the differences. But first, the similarities are, in the gut tube there are 4 layers. Mucosa, under that we have some mucosa, then we have the muscular externa, and then the serosa. So in the stomach, we'll have the peritoneal lining. This is the peritoneal serosa. And one difference what we find in the muscular externa is, in the stomach, we have one additional layer, which is oblique muscle layer. We have mentioned earlier that in the gut tube, there's an inner circular and outer longitudinal muscle. But in the stomach, we have got, in addition to this outer longitudinal muscle, inner circular muscle, one additional oblique muscle layer that is a typical feature of the stomach. And you will find that there is one difference in the epithelium as well. The epithelium in the stomach becomes simple columnar epithelium, and it will forming some glands, which are the gastric glands, having several type of cells for secretion purpose. So in the stomach, we are having some gastric pits, and these gastric pits are continuous with the gastric glands. As you mentioned, the epithelium is going to form the glands, mostly found in the mucosa. And let us magnify the lining of the gastric glands to discuss some of the cells involved in the secretion. As we do that, we'll find we have got some surface mucus cells which are going to secrete the mucus, because the stomach is having a lot of hydrochloric acid. You have to neutralize the acid. These mucus cells are not only on the surface but also on the neck of the gastric gland. So they are called as mucus neck cells. We have to remember that the mucus neck cells, which produce mucus, and the parietal cells, which produce the acid, hydrochloric acid, both of these cells are found in the upper half of the gastric gland. So 2 cells in the upper half, and you can remember 2 cells in the lower half of the gastric gland, which are the chief cells producing enzymes like pepsin enzyme, and then some cells producing hormones, the endocrine cells, near the base of the gastric gland. So may it be the chief cells giving us enzymes like pepsin enzyme, or may it be the endocrine cells. They are present in the lower half of the gastric gland. We'll be looking at certain details in the discussion of the gut tube later as well. Let us now move on to the details of the layers we find in the small intestine as well. It is to be understood that small intestine is actually involved in absorption of the nutrients relatively to a larger extent, and that is why it will have some additional features. The small intestine will have 3 components: duodenum, jejunum, and ileum, and all the 3, they have some features to increase the intestinal absorption. Let us magnify this picture now, and as evident, it is going to have what is called as plicae circularis, which are mucosal folds to increase the surface area of absorption. Then there are some finger-like projections in the mucosa which are called as the villi, and on the microscopic level, there will be some microvilli as well. So these 3 components, the plica circularis mucosal folds, and the villi plus microvilli, they are typical feature of small intestine. They are absent from the stomach, and they are absent from the large intestine as well. They are present only in small intestine. And in small intestine also, as we mentioned, there is duodenum, jejunum, and ileum. These features start in the duodenum, are maximum in the jejunum, and then they are reducing in the ileum. It may be seen that ileum is having very few plicae circularis and the villi microvilli. So there will be maximum in the middle portion, that is the jejunum. And as we know, the small intestine, since it is a part of gut tube, will have the mucosa, submucosa, muscular externa, and the serosa. We have to understand the serosa, which is peritoneum for the gut tube, is lined by simple squamous epithelium. It comes under the category of mesothelium, and mesothelium as such, which is simple squamous epithelium, not only includes the serosa, but under the mesothelium, you can include the pleura and pericardium as well. So we know there are 3 cavities having their own membranes. If it is gut cavity, the peritoneal cavity, you have the peritoneum. If it is a pleural cavity, you have the pleura. In the pericardial cavity, you have the pericardium. Now, pericardium or the pleura or peritoneum, they are all considered under the mesothelium. And may it be the pleura or pericardium or the peritoneum, they are all lined by simple squamous epithelium. We would like to look at the details of the respiratory tube as well now. And going back to this diagram, we are looking at the trachea. As the basic organization of the body tube, you'll find that even the respiratory tube is having the basic 4 layers. Let us magnify this diagram now, and you will find even here we are having the mucosa lining the lumen. Under that we have the submucosa, and there will be some muscle layers. We are not calling it as the muscular externa, but there are some muscle layers, and the outermost is connective tissue adventitia. So again, the basic structure of the body tube is being maintained, but the epithelium in the respiratory tube is different. you will notice it is pseudo-stratified ciliated columnar epithelium for most of the beginning of the respiratory tube, starting from the nose, then moving towards the larynx, the trachea, the bronchus. We'll find that it is pseudo-stratified ciliated columnar epithelium. But why are we having cilia here? For mucociliary clearance. The respiratory tube is having goblet cell which is producing the mucus, and the cilia are moving the mucus outside. See, when we are breathing in, some dust particles will come in, some bacteria virus may come in, and it is trapped in the mucus, which needs to be coughed out. And to move it outside, the cilia will be working, mucociliary clearance. Sometimes we may have problems like Carter-Jenner syndrome, immotile cilia syndrome. The cilia is not moving. And in Carter-Jenner syndrome, there can be chronic sinusitis, trapping of the mucus and the bacteria, plus there can be bronchiectasis also. The infective organisms are staying back in the lungs. So bronchiectasis, sinusitis, these are the features of Carter-Jenner syndrome, which is immotile cilia syndrome. Now we will find one typical feature in the respiratory tube. Along with the smooth muscles in the muscular layer, we are having some hyaline cartilage as well. Mostly it is hyaline. There can be elastic cartilage as well in the respiratory tube. But why are we having the hyaline cartilage? To give rigidity, patency to the lumen. The trachea must be patent. We are breathing the air inside and we cannot afford the tracheal lumen to get collapsed. It will hamper the breathing. But this hyaline cartilage, which begins from the nose region and is present in the larynx, trachea and bronchus, is lost at the bronchiole level, and beyond that, bronchioles do not have hyaline cartilage. They have the smooth muscles there. So, distally the hyaline cartilage is being replaced by the smooth muscles. But why do we need smooth muscle in the respiratory tube? It is for bronchoconstriction, to reduce the lumen of the bronchus and bronchioles. But why you want to reduce the lumen of the bronchioles? Say for example, we are walking in a city and there is a lot of pollution, lot of dust and smoke is coming. That time, you don't want to inhale that kind of air. There will be bronchoconstriction. Those smooth muscles will be helping us in reducing the lumen. Now you have been walking, you came out of the city and you are in a village, there's a fresh air and you want to take more of that. And then the bronchus can dilate. So bronchoconstriction, under the parasympathetic system, the smooth muscles are working. Then we'll be looking at the lining of the renal tube as well. For example, this is the urinary bladder and we are going to magnify this diagram now. The renal tube is mostly lined by the transitional epithelium, which is multi-layered stretchable epithelium. Sometimes you'll find it is 10 cell layer thick and which may then reduce to 3 to 4 layers. And why does that happen? See, it is urinary bladder which is stretchable. If you have a lot of urine in the urinary bladder, then the epithelium is stretching and it becomes 3 to 4 layer thick. But as the urine is evacuated and there is no more urine in the urinary bladder, that same 3-4 layer epithelium becomes 10 cell layer thick. So it can stretch whenever there is a requirement to store the urine. Now that was the mucosal layer. There is a muscle layer also, that is mostly we will call it as the detrusor, as we are looking inside the urinary bladder. And the fundus of urinary bladder can have lining of the peritoneum as well. This detrusor muscle helps in evacuation. We have learned parasympathetic system is for evacuation. So whenever there is parasympathetic activity, it will increase the contraction of the detrusor and urine can be evacuated. Coming back to this diagram, we want to discuss this component as well, lining epithelium of the skin, which we mentioned is similar to the lining epithelium of the esophagus, stratified squamous epithelium. But there is one difference. The skin is a dry surface, so it will be keratinized, whereas the esophagus is a wet surface and it is non-keratinized. Remember, all the wet surfaces, may it be the esophagus or the stomach or the small intestine or the respiratory tube or the renal tube, they are all wet surfaces and they are non-keratinized. If you have keratin, the surface will have a tendency to become dry. Now we are magnifying this diagram of the skin, looking at some of its layers. As we mentioned, it is stratified squamous epithelium but is keratinized, keeping it dry. And when we are looking at subepithelial connective tissue, there will have the dermis. The epithelium is called epidermis and under that is dermis, and dermis itself will have 2 layers. layers. There is some papillary layer of the dermis, which is superficial, and then there will be a deep reticular layer of dermis, which is not evident here, and we'll be discussing it in more detail. This is just an overview we are having. There can be glands in the skin epithelium like sweat gland and sebaceous gland to keep it moist and to keep it lubricated. Now we mentioned that the skin epithelium and the esophagus epithelium, they have some similarities and some differences. Let us look at a diagram to find out the differences. We are going to compare the skin epithelium, a histological picture, with the esophagus epithelium. In fact, we'll be looking at genital tube, the vaginal epithelium. The epithelium of vagina is very similar to epithelium of the esophagus. Non-keratinized stratified squamous epithelium is found in esophagus and vagina as well. And here we have got the stratified squamous epithelium, which is non-keratinized. As is evident here, this is a specimen we have taken from the vagina, the genital tube. There are two diagrams showing the details of the vaginal epithelium, which is non-keratinized stratified squamous epithelium. And now we are going to compare it with the skin which we have taken from the sole, which is shown here. So these are the two diagrams which are showing stratified squamous epithelium, but it is keratinized. And we want to know how this keratinized epithelium is differentiated from the non-keratinized epithelium. At one place we have the vaginal epithelium, and other place we have the skin of the sole, and we are going to magnify it now. So we see that though their epithelium is similar, one basic difference is in the skin we are having dead squamous cells towards the outer side, whereas in the vaginal epithelium or the esophageal epithelium, even the superficial cells are living and they are having these nuclei. So even the superficial cells which are towards the surface, they will have the nuclei because they are living epithelial cells, which is not seen in the case of skin. These cells which are towards the surface of the skin, they are dead and there are no nuclei at this level. If you want to search for nuclei, they are at the deeper level. These cells will have the nuclei. So as it is evident, nuclei are present in the superficial layers of the skin as well, but there is a layer of desquamated dead cells as well. So this is keratinized stratified squamous epithelium, and this is non-keratinized stratified squamous epithelium.